Now I'll talk about the uh, next drug here, that is carbamazepine. Chemically, it is related to imipramine, and one of the old drug, 1960s, it has been discovered, and at that time it was used for trigeminal neuralgia, and nowadays can be considered as an first-line drug for the anti-epileptic drug treatment. And its pharmacological actions, if you see, they are quite similar like phenytoin. Carbamazepine modifies the maximal electroshock seizures as well as raises threshold to PTZ and electroshock convulsions. While phenytoin was only acting on the modifies the maximal electroshock seizure, not for the PTZ. Okay, so this is what the difference. It also inhibits kindling, though its action on sodium channel prolongation of inactivated state is similar to phenytoin. So you remember the previous phenytoin mechanism, what it does on the sodium channel, it also does the same. The profile of action on neuronal system in brain is different. Carbamazepine experts a lithium-like therapeutic effect in mania and bipolar mood disorder. Means carbamazepine has also gained a reputation to act on mania and bipolar mood disorders. Later, maybe we'll discuss on these chapters as well. It also has antidiuretic action, probably by enhancing ADH action on renal tubules. Now we'll see the mechanism. Like phenytoin, carbamazepine limits the repetitive firing of action potential. It's slowing the rate of recovery of voltage activated sodium channel from the inactivation. If you are giving the therapeutic concentration, it can attain some therapeutic, means if you give in the therapeutic doses, it attains the concentration in CSF. The effect of carbamazepine are selective at these concentrations, means how much the concentration achieved, on that the effect will be dependent on. The carbamazepine metabolite 10 to 11 epoxy carbamazepine also limits sustained repetitive firing at medically relevant concentrations, suggesting that this metabolite may contribute to the anti-seizure efficacy of carbamazepine. So, during the ADME, it has been observed that it is converting into one of its metabolite, and that metabolite is may be responsible for its action for anti-seizure activity. Let's see the pharmacokinetic of this drug as well. It also having a very poor water solubility. 75% bound to plasma protein and metabolized in liver. It is also metabolized in liver. What is the by which method? Oxidation method, and converts into its active metabolite. Okay, which is actually the responsible for the activity. It is also using hydroxylation and conjugation method for the metabolism. It is a substrate as well as inducer of CYP3A4 and other drugs metabolizing enzyme. Initially, its plasma T-half is 20 to 40 hours, but decreases to 10 to 20 hours on chronic medication due to autoinduction of metabolism. Okay, so whenever metabolism induced by itself, its T-half reduces. ADR of carbamazepine produces dose-related neurotoxicity, sedation, dizziness, vertigo, diplopia, and ataxia. You can see these are the common ADR what the phenytoin also produces. Vomiting, diarrhea, worsening of seizure also happens on higher doses. Coma, convulsions, and cardiovascular collapse. It is on higher doses. Hypersensitivity reactions in rashes, photosensitivity, hepatitis, lupus-like syndrome, and rarely agranulocytosis and aplastic anemia also happens. Some degree of leukopenia due to hypersensitivity is also very common. Water retention and hyponatremia can occur in the elderly because it enhances ADH action. Now you remember the effect of this drug on ADH action is a very important link for explaining lot many drug interactions. Increased incidence of minor fetal malformations has been reported. Fetal malformations, it means not a good drug to give for the pregnancy. Its combination with valproate doubles teratogenic frequency. In some cases, if you combine it with valproate, the ADR severity, for example, teratogenic effect will be higher. What the interactions are? Carbamazepine is an enzyme inducer, can reduce efficacy of haloperidol, oral contraceptives, lamotrigine, and topiramate. Whenever we say enzyme inducer or enzyme inhibitor, we are actually talking about the liver enzymes. So the metabolism, most of the time metabolism happens in liver and these enzymes are involved. So these drugs are changing the metabolism, either enhancing or decreasing by changing the enzyme levels. Metabolism of carbamazepine is induced by phenobarbital, phenytoin, valproate, and vice versa. Erythromycin, fluoxetine, isoniazid inhibit metabolism of carbamazepine. So remember, these interactions are very important for especially for the pharm day students. Uses: carbamazepine is the most effective drug for CPS and share first choice drug status with the phenytoin for GTCS and SPS. Here I am writing in the short terms of the type of epilepsies. Trigeminal and related neuralgias, carbamazepine is the drug of choice. Drugs benefit by interrupting temporal summation of afferent impulses. Means what drug is doing? Temporal summation of afferent impulse. Summation means collectiveness, collective impulses, right? So it changes that, and by that it is reducing the impulses. Carbamazepine is not an analgesic but has a specific action of these neuralgias. About 60% patients respond very well. Phenytoin and baclofen are less efficacious alternatives. Manic depressive illness and acute mania. It has also been used for manic depressive illness and acute mania as an alternative to lithium, because lithium is the main drug of choice for the mania. Okay, so now we'll move to the next next class drug, that is ethosuximide. The most prominent action of ethosuximide is antagonism of PTZ induced clonic seizure. It means if the epilepsy been caused by the pentylentrazole, then this is a very good drug to antagonize. It means now if you are testing your drug for the epilepsy by using the chemical method, then don't take phenytoin as a standard, but take the ethosuximide as a standard. It raises seizure threshold but does not modify maximal electroshock seizure or inhibit kindling. Clinically, it is effective only in absence seizures. You remember, it is very much effective on absence seizure, while phenytoin was not effective for the absence seizure. The primary action appears to be exerted on thalamocortical system, which is involved in the generation of absence seizure, right? So it means thalamus and cortex region it is affecting. Thalamic neurons exhibit prominent transient current, which is low threshold calcium current due to inward flow of calcium through T-type calcium channels that act as a pacemaker and amplifies repetitive spikes in EEG. This is what I'm talking, what the thalamocortical system does, and so your drug is affecting this particular area. Ethosuximide selectively suppresses T current, right? Because T current is taking part into the firing without affecting other type of calcium or sodium currents. It also does not potentiate GABA at therapeutic concentration. You remember that phenytoin and carbamazepine does that, but ethosuximide doesn't. This correlates well with its selective action in absence seizure. Plasma T-half average 48 hours in adults and 32 hours in children. Ethosuximide is rather slowly but completely absorbed. That was the problem with the phenytoin as well as carbamazepine. This is not a protein-bound drug. That is again different from those previous drugs. Evenly distributed in body and largely metabolized in liver by hydroxylation and glucuronidation, and excreted in urine about unchanged form. So any drug which is using the hydroxylation and glucuronidation, if you are giving together, will be the reason for drug interaction. EDRs. Dose-related side effects are gastrointestinal intolerance, tiredness, mood change, agitation, headache, drowsiness, and inability to concentrate. These are very serious behavioral adverse reactions will be there. Hypersensitivity reactions like rashes, blood dyscariasis are rare. No liver or kidney damage. Use what are the uses here? The only indication for ethosuximide is absence seizure. Here just put the hyphen. The only indication for ethosuximide is absence seizure. In that also it has been superseded by valproate. And dose what you are preferring? 20 to 30 mg per kg per day. Okay, so now we'll move on to the next drug here, that is the valproic acid, which is also called sodium valproate. It is a branched chain aliphatic carboxylic acid with a broad spectrum anticonvulsant action. It is more potent in blocking PTZ seizure, like the ethosuximide. It's also very much blocking the pentolin tetrazole induced seizures than in modifying maximal electroshock. If you see that the previous two drugs and these two drugs are having quite different method of action. Establishment of chronic experimental seizure foci and kindling are also prevented. Anticonvulsant doses, valproate produces little sedation or other central effects. Mechanism of action, what it does, there are multiple mechanisms like the previous drugs. It also has a multiple mechanism. Number one, a phenytoin like frequency dependent prolongation of sodium channel inactivation. You see almost every drug has this effect except the I think ethosuximide. Weak attenuation of calcium mediated T current. Augmentation of release of inhibitory transmitter GABA by inhibiting its degradation, as well as probably by increasing its synthesis from glutamic acid. So it is also facilitating the GABA's action, but in a different manner. How it does? It is helping to reestablish the GABA's function by inhibiting the GABA degradation as well as the more production of GABA from the glutamic acid. However, responses to exogenously applied GABA are not altered. What is the pharmacokinetic in ADR? Oral absorption of valproic acid is good. It is 90% bound to plasma proteins, completely metabolized in liver by oxidation, and glucuronide conjugation excreted in urine. See, compared to previous drugs, it is a good oral absorption, while the phenytoin was not. It is 90% plasma protein, while ethosuximide was not. Plasma T half is 10 to 15 hours, but anticonvulsant effects are longer lasting. The toxicity of valproate is very low. But even though there are certain symptoms, certain ADRs, anorexia, vomiting, heartburn are common. Drowsiness, ataxia, and tremor are dose-related side effects. However, cognitive and behavioral effects are not prominent. Alopecia, curling of hair, and increased bleeding tendency have been observed. Rashes and thrombocytopenia are infrequent hypersensitivity phenomena. Asymptomatic rise in serum transaminase is common. Monitoring of liver function is advised. So this is again an important feature, that rise in serum transaminase level. Okay. A rare but serious adverse effect is fulminant hepatitis in children. Those with hepatic disease or who receive other anticonvulsant or hepatotoxic drugs are at greater risk. Pancreatitis is also reported. Long-term use of valproate is in young girls has been associated with higher incidence of polycystic ovarian disease. and menstrual irregularities. Means it is causing PCOD as well as menstrual irregularities. Used during pregnancy, it has produced spina bifida and other neural tube defects in the offspring should be avoided. Right, this is a spinal cord defect that's called the spina bifida. Doses: adults start with 200 mg, maximum 800 mg, children 15 to 30 mg per day. Main uses of valproic acid. Valproic acid is the drug of choice for absence seizure. It is an alternative adjuvant drug for GTCS and SPS and CPS. Myoclonic and atonic seizure control is often incomplete, but valproate is the drug of choice. Mania and bipolar illness as alternative to lithium. Valproate has some prophylactic efficacy in migraine. Again, very important drug interactions. Valproate increases plasma level of phenobarbital by inhibiting its metabolism. It displaces phenytoin from protein binding site and decreases its metabolism, phenytoin toxicity. Valproate and carbamazepine induces each other's metabolism. Concurrent administration of clonazepam and valproate is contraindicated because absence status may be precipitated. Fetal abnormalities are more common if valproate and carbamazepine are given concurrently. So these are some very potential interactions here. Therapeutic strategies for managing newly diagnosed epilepsy. You can see here newly diagnosed epilepsy. First choice of drugs for me is not very clearly visible. Second choice drug. You can try to look into it. If it is not readable, let me know. I will send you the file again, separate file for this. Summary of the anti-epileptic drugs. Here you can zoom it and see here drugs, this side mechanism, and this side adverse effect and comments. So this chart is quite enough to revise the whole chapter. Here this side you just see the drug and their respective mechanism of action, and then the adverse effect and comments. So may be helpful for you. Now here there are some assignment for you, which is homework. You need to do the homework for these drugs: Valproic, gabapentin, very important, lamotrigine, phenobarbital, zonisamide, benzodiazepine. Benzodiazepine already you are covering there, so that information can help you out here also. Short note on epilepsy therapy. Right, there will be a short note on epilepsy therapy. What I have given in the one first diagram just before 2 slide, a kind of summary of that will be come into the epilepsy therapy. These are the references I have used for making these slides. You can go through with the Robbins, which is the basic pathophysiology book, Dipiro for pharmacotherapy, Rangandale, Harvey, Goodman, and K.D. Tripathi. These are our pharmacology books. Most of them are available in our library. Please go through for more details. Thank you so much for listening this.